Thank you very much. I will discuss a little bit some new data and about mechanical ventilation after cardiac arrest and in patients without a lung injury. No conflict of interest to declare for this specific lecture. When we look at the patients with cardiac arrest, we are mainly focused on the resuscitation maneuver, and we look less carefully what's happened to the patients afterwards. So we should be more interested in the next future on the secondary brain damage after cardiac arrest. And you know that we have two possibilities. One is that we have a brainstem recovery or brain death, and in case of brainstem recovery, we can have a recovery of the cortical function, but unfortunately, in many cases, a vegetative state. So I will try to discuss today that mechanical ventilation can play a role to try to prevent, as much as possible, vegetative states after cardiac arrest. And this is well described and discussed in this recent review on intensive care, where you see here the 10 strategy which are supposed to increase survival in cardiac arrest patients. And it's not only anymore about BLS or ALS or early AED programs, but as you can see here, there's a major importance in the post-resuscitation care, and mechanical ventilation play a role in post-resuscitation care in these patients. So we are moving, and this is our recent papers, including ours, discussing this issue, related to the fact that the current challenges for cardiac arrest are the post-cardiac arrest management more than therapies and management during cardiac arrest, which of course has to be considered. So we are moving from the concept to prevent from the concept to cure to prevent eventually development of respiratory failure or organ failure after cardiac arrest. So there are some preclinical studies. These are some of us from our group. We look at the effects of mechanical ventilation in non-injured animals. And you see here, these are the extraction of proteoglycans from the extracellular matrix. And you see here, during spontaneous ventilation or just after 4 hours of mechanical ventilation with so-called physiological low tidal volume and progressively increasing tidal volume. And you see here that when ventilated animals, normal animals with high tidal volume, we have a progressive fragmentation of the extracellular matrix. And on the other hand, you see here that even mechanical ventilation for 4 hours with relatively low tidal volume at 7 meters per kilogram was associated with an increased defragmentation of the extracellular matrix. So even a few hours of mechanical ventilation, even with protected tidal volume, may induce fragmentation of the extracellular matrix. And this is important because, as you can see here, the fragments of the extracellular matrix may induce and promote inflammatory response in the lung. So what we believe is that the first target of ventilator-induced lung injury is the fragmentation of extracellular matrix, and this occurs in normal lungs, even with relatively low tidal volume. And then we move on, it was discussed before very clearly, the concept of driving pressure. And the driving pressure, I would like to add some more interpretation on that. Is the tidal volume divided compliance, as discussed before. And if you consider the compliance is correlated to the amount of aeration in the lung, you can interpret driving pressure as a sort of specific tidal volume related to the amount of aeration. So it's a very easy parameter at the bedside to know how much is the relatively influence on tidal volume on that amount of aeration. And this is what we are following from the concept of stress, so the transpiratory pressure attending inspiration, to the concept of strain, which is again the ratio between tidal volume and lung volume, which is driving pressure, to the concept of driving pressure per se, as it was discussed today. But now we are moving on to another concept, which is energy. Energy is the amount of driving pressure squared times the elastance. But anyway, the energy that you deliver to the lung is associated to the increase in driving pressure. So higher is the driving pressure, higher is the energy to the lung, higher is the ventilator-induced lung injury. And minimal changes in driving pressure are associated with major increase in the energy that you deliver to the lung. The second concept is the concept of power. Power is the amount of energy delivered per time. So we're moving from the concept of energy alone to the respiratory rate, because higher is the respiratory rate for the same energy is higher the amount of power, and this is associated with higher amount of injury. And finally, we developed with Marcelo, Patricia Rocco, and colleagues the concept of intensity. Intensity is the amount of power delivered to the amount of the area. So can you imagine if you have a more dishomogeneous lung, even if you are giving the same amount of power, you expect much more injury if you deliver the same amount of power for a larger amount of aeration. So this is, I think, is some concept, basic concept that we have to think about in the next future to optimize mechanical ventilation in non-injured and also in injured lungs. And these are very nice data from Patricia Rocco lab, and you can see here in animal again, this is interleukin-6, which is an inflammatory mediator, and this is the amphiregulin, which is a biomarker associated with the amount of stress of the alveolar cells. And you see here a very good correlation of both of them with the amount of power. So energy related to the respiratory rate. Sorry here, this is not amphiregulin, it's again interleukin-6, the mistake, but there was no correlation between amphiregulin and interleukin-6 on amount of power when we look at the changes in PEEP. So the most important target here was the amount of tidal volume and respiratory rate and not the static strain in this particular study. Tidal volume in non-RDS, this is a study we performed a few years ago in which we clearly showed that tidal volume per se in non-RDS patients, including neuro patients and patients after cardiac arrest, which are the majority of patients, including patients after surgery, tidal volume and the risk to develop pulmonary complication in intensive care. So higher is the amount of tidal volume that you deliver in non-injured lungs, neuro or cardiac patients or postoperative patients, higher is the risk to develop pulmonary complications, sorry, not postoperative. And this was also associated with a tendency towards a better survival at 0.05, and again, a less amount of complication. And this was another study, again, in non-injured lungs, when you look at the effects on patients' free mechanical ventilation days, and you see this much higher when patients were ventilated with a tidal volume around 6 to 7 meters per kilogram as compared to higher levels. So clearly, in non-injured lungs, ventilation with low tidal volume may be associated with a better outcome. What about PEEP in RDS? There are only 2 randomized trials published. This is a very old study on New England Journal of Medicine. Tidal volume was not specified at that time. 2 levels of PEEP, 0 and 8. In a patient at risk with RDS, very few patients. And you see there were no difference at all in terms of outcome. There's another study, more recent, in patients, including patients with cardiac arrest and neuro patients, more protective tidal volume, PEEP 2 and 5, and in this study, PEEP 5 was associated with less episodes of hypoxemia and less ventilator-associated pneumonia. So it seems that to apply a PEEP 5 associated with tidal volume protective can be a good strategy to prevent complication in non-injured lungs, even if we need a larger studies. I don't know here, This again is the study was shown before, published in Lancet recently, in which we found that driving pressure was associated with increased postoperative pulmonary complication. This is in a surgical population of patients. And then with patients with an increase in driving pressure, when the PEEP was increased, this was associated with more complications. So again, this suggests us that in non-injured lungs, when we increase PEEP, we should not increase at the level that the driving pressure increases. So give us some additional information on this issue. So these are data in cardiac arrest patients. I think it's the largest study actually published in observational data with Yuda Suterazan and colleagues that was fellow in our unit last year. You see, first of all, the different cohort of patients from 98 to 2004 to 2010. This is from the Esteban and Fernando Frutos database. And as you can see, there are no major changes in age, female, and so on. But the days of mechanical ventilation were a bit increased with time, and mortality, however, was very high, around 50–56%. So first message, patients after cardiac arrest in this last year, they have a high mortality. This does not mean that they have good neurological outcome. Almost more than 50% have a very poor neurological outcome. So it's a major problem for these patients. And this is how are they ventilated. Actually, in 2010, you see the tidal volume much less than in the previous year, from 9 to 6, so we are going toward a protected tidal volume. PIP is a little bit increasing from 3.5 to 6, so which is, I think, is good in terms of protection and what we discussed before. And also respiratory rate is a little bit increasing, and mainly because we fear a lot the CO2 in these patients. But we show you that this is probably not always the case. But anyway, this is the trend that we are going to do in cardiac arrest patients. Most of them, they are over-oxygenated, as you see here. PO2 is 120, or up to see here, standard deviation 60. There is no reason for that, to have hyperoxia in this patient. I will show you briefly. PCO2 is around 40, but you see here a quite large deviation of PCO2. This is a trend that, regarding mechanical ventilation. We are using less and less controlled mechanical ventilation in this patient, except the first 2 days, 3 days, and much more pressure support. Much less other type of ventilation are used in this patient, so more assisted ventilation in these kind of patients after the first few days. What about complication? You see here that RDS is around 10% in these patients, so quite frequent, and acquired ICU pneumonia is decreasing on the other side. So there's a decrease in acquired ICU pneumonia, the same level of RDS. The lung seems to be protected, more protected with more protective mechanical ventilation. This is not randomized controlled trial. However, we found a major increase in other organ failure, especially cardiovascular failure and also renal failure. So the cardiac arrest patient is becoming a more internal medicine patients than only the brain patients. This is, I think, is extremely important. This is the weaning. The weaning you see here, that patient weaned are around only 40%, so almost 55% have difficult weaning, so it's a difficult patient. And among the type of weaning, you can see here that we have very often the spontaneous breathing trial in CPAP. A little bit less used is the gradual reduction of pressure support, even if there is an increase now, you see, from 12 to 35, because we are using more and more pressure support. And among pressure support, pressure support is the most used. So CPAP or T-tube, CPAP mainly and T-tube are the most frequently used, but there is a major increase in pressure support, and I think is a good way. Which are the factors which are going to predict mortality in these patients? Age, of course, and PO2, but mainly hypoxia or relative hypoxia, when PO2 was less than 100 in this patient in the first days, and of course cardiovascular shock, which is associated with mortality. But interestingly, we found that the use of sedative drugs in the first 2 days was associated with better outcomes. So more we maintain the patient sedated in the first 2 days, we are likely to have a better outcome. And this is interesting. We are going to have less hypothermia, or more target temperature management, more precisely, and more sedation. This, I think, is the way we are going to go. So less aggressive treatment on the brain, and within protection and more sedation in the patient in the first days. This, I think, is extremely important in the change of treatment of cardiac arrest in the next future. We also found that higher plateau, the factor associated with RDS development, was markedly associated with higher plateau pressure. So take care when the plateau pressure is higher than 16, 17, this increases the risk factor. And ICU acquired pneumonia was associated again with high tidal volume and lower applied PEEP level, lower than 5. So again, everything is matching also in cardiac arrest patients. Low tidal volume, low plateau pressure, and moderate PEEP level. What about oxygen and CO2 after cardiac arrest? This is a meta-analysis we perform again with UDA. This is looking at hypoxia and normoxia. Hypoxia is defined in less than 60. And you see here that there is a clear increase in mortality when you have hypoxia in these patients that you have to avoid. And in this particular meta-analysis, we also found hyperoxia, but higher than 300 was associated with worse outcome. What about normocapnia and hypocapnia? Is a clear evidence that hypocapnia, is associated with a worse outcome, as well as hypocapnia. So hypercapnia and hypocapnia were associated with worse outcome. And also there were association with poor neurological outcome. However, while for hypocapnia, so less than 35, we should be absolutely avoided, there is much more discussion about hypercapnia after cardiac arrest. This is a very nice study that they showed a little bit different results from our study. They found that hypercapnia was associated with a little bit improvement in outcome. So now there is actually a study planned to look at the little bit hypercapnia that should increase the cerebral perfusion. Might be mild hypercapnia between 45 and 60 might be helpful to protect the brain after cardiac arrest. But actually, I think we should recommend normocapnia between 35 to 45, but new study will clarify the role of moderate hypercapnia to protect the brain. So this is the PREVENT study, which is a larger study in non-injured lungs. And just to show you that, again, tidal volume was found protective against pulmonary complication, and interestingly, patient with higher respiratory rate was associated with pulmonary complications. So again, the concept of power that I showed you before is quite interesting. These are two studies actually randomizing patients in non-injured lungs. It's a Dutch study, the Spanish study, low tidal volume and moderate higher tidal volume on outcome. Just to conclude, I show you the preclinical studies shows that protective ventilation with lower tidal volume and moderate level of PEEP appears to be protect the lung in healthy lungs. After cardiac arrest, even if we have no randomized trial, I think we can suggest low tidal volume between 6 to maximum 8 meters per kilogram predicted body weight, plateau pressure less than 16, and look at the driving pressure. We know now that it's very important also in non-injured lungs, at least less than 13 centimeters of water. Minimal respiratory rate in order to achieve normocapnia, in order to avoid excessive power to the lung. A PEEP of 5 seems to be a good choice in these patients, not higher. And if you increase the PEEP, look at the driving pressure. Don't use PEEP level in which driving pressure increases, when especially also in non-injured lungs. Avoid hyperoxia, which means higher than 30 millimeters of mercury. That can occur, I would say, avoid higher than 150, but we have no clear data on that. For sure, to avoid hypoxia, less than 60. Our data suggests also less than 100, so I think that a good limit is between 100 and 150. And avoid, for sure, hypocarbia. New studies will clearly define the role of moderate hypercapnia between 45 and 55 to protect the lung, but they don't suggest actually to do this in clinical, routine clinical management. And of course, new randomized clinical trials are needed to better define the role of protective ventilation after cardiac arrest. Thank you very much.